Okay, we're going to get started so we stay on time. My name is Dan Samo. I'm moderating this section, and in the ACOEM's new process, we have someone from the resident section who's going to introduce our next speaker. I think you're really going to enjoy this. I've met David in one of our Central States meetings, and this is a great presentation. So I hope you enjoy it. And Becky will introduce.
Hi, I'm Becky Steinberger from the Resident and Recent Graduate section. I'm here to introduce Dr. David Tan, who's an Associate Professor of Emergency Medicine at Washington University School of Medicine in St. Louis, and Chief of the EMS section. He's board certified in both emergency medicine and EMS medicine. Dr. Tan provides medical oversight to multiple first responder, police, fire, and EMS agencies, including the paramedic and first responder programs at Mallinckrodt Pharmaceuticals in St. Louis. As a technical physician for a regional SWAT team, he brings extensive experience to our discussion today for preparing your workspace for the mitigation of an active violence encounter. Dr. Tan?
Thank you very much. I really appreciate the invitation to be here. Can everyone hear me okay? I know that this is sometimes not working, but if you can't hear me, just call it out. I'm in the art house, so we're not going to be quiet. So, some disclosures. I finally have some, which is awesome. I have some other jobs, including medical director for St. Charles County Police Department, which is right outside of St. Louis. Mallinckrodt, as was mentioned. I'm an unlimited partner in Catalyst Tactical Consulting, which is just we do training for schools and police departments and anyone else who wants this type of thing. As she mentioned, my background, I'm probably one of the few, I'm sure I'm not the only one of the few practicing ER guys here at the conference. But I got to tell you, I came to the morning session. It's absolutely fascinating. The public safety section is fascinating, and I come to realize that there's a lot of overlap and tons of things. I was telling Dr. Samo, I really wish I didn't know about this conference now, because I have another conference I need to come to. This is really, really good. So I also work with the federal program, the Counter Narcotics and Terrorism Operational Medical Support School in Washington, teaching medics how to be SWAT medics, and we'll touch on that just a little bit. So when people ask me what it is I do, and heck, even my own family sometimes they don't quite get what I do, because they think, well, can I go to your office, or can I come to your office? I tell them I don't have an office. This is not my. This is a typical doctor's office, is what you would think of, but actually, this is my office. I still do work some emergency medicine or ER shifts, about 6 to 8 shifts a month, but really, the vast majority of what I do is field medicine. So I'm one of the few docs that get to do EMS full-time. So I'm usually in the back of a fire engine or an ambulance or a police car, front seat of a police car for my daily work, which is really a lot of fun. So a little bit about my background. My journey here this afternoon with you in Chicago started about 3 years ago, actually, when in 2013, I was part of a plant-wide drill. I'm not sure if you're familiar with the physical plant of Mallinckrodt Pharmaceuticals. It's a ginormous plot of land right on the banks of the Mississippi in St. Louis, at the foot of the McKinley Bridge. I don't know how many dozens of acres, multiple buildings. I mean, it's a huge complex. We make fentanyl there, sufentanil, precursor compounds for other pharmaceutical agents. It's a really neat place to work. But we did an armed intruder drill in October of 2013. It wasn't a huge plant-wide drill. It was more security. My medics, we have paramedic staff on the plant 24 hours a day, 7 days a week. Just one. But we do have about a dozen or more first responders. These are employees who have volunteered to go through the EMR, or Emergency Medical Responder Program, and they are fantastic. They're completely volunteer, like I said, so they want to do it. Their hearts are in it, and they're a fantastic resource for the paramedic. But one of the things that we learned in the after action report
was that really everyone felt that this was too valuable to kind of just keep to our little core group. They wanted to bring this to the entire plant because they felt like, unfortunately, in this day and age, this type of training and discussion was needed. And so about 3 months later, we did a whole plant-wide employee enrichment seminar in 2014, and we actually presented a lot of these concepts we're going to talk about today to the entire plant. And it just so happened that the occupational medicine physician there at the plant, who worked there that I work with very closely, was on the planning committee for the regional OCMED conference and said, you've got to bring this to the regional conference in 2015. And so I did. And it just so happened that someone in the audience there was on the planning committee for this conference and said, you know, this would probably be pretty useful for our national conference. And so again, I'm really appreciative of the invitation to be here. Our objectives are really pretty simple. What I want to do is define what an active shooter is, describe some current trends and lessons learned from these incidents. And what I hope that you leave with today is some resources, some ideas for training, and what you can do to go back to your facilities to maybe mitigate these incidents and reduce the loss of life. And more importantly, how to view this globally as something that's not going to be unique to just your plant or your office, but really your whole community. So engage local police resources as well to come and work with you. And then talk about a practical tool of this mitigation, which is a tourniquet usage. Still lots and lots of myths out there about tourniquets, how and when or if to use them. So we'll run over that too. Now, big picture, real quick, there are classes ranging from 2 days to 2 weeks dealing with what we're talking about. We have about an hour-ish, hour and a half. So this is going to be a very brief overview, okay? I'm hoping to just whet your appetite a little bit so that you'll go back and say, I need to learn more about this. And I actually do have a handout that I'll pass out in here in a second. The events in Sandy Hook was probably one of those events that we all remember where we were at the time. You know, it's one of those sentinel moments where we kind of remember what happened and what we were feeling. But what's interesting is that what very few people realize, or at least know, is that on the exact same date, on the other side of the world, in China, there was another attack. And I don't know about you, but that's just disturbing. I actually saw the video, and it's just disturbing. That's a still shot, a man with a knife, because they don't have guns really over there, but they have knives, big ones. And he went around to the Chengpeng Village Primary School and stabbed 22 children on the exact same day. So whether it's, we call it here in America active shooter because that is the weapon of choice typically, the firearm. But in other parts of the world, understand this. The concept of an active killer, of active violence occurs across the globe. So it's not just our problem. What makes us unique is that we have firearms, but everyone else uses knives and clubs, etc., okay? But the active killer, the active violence incident occurs everywhere. It's not just here. So whether it's a shooter, a killer, what have you, an active shooter is a criminal who is focused on killing as many people as possible in as short a time frame as possible. Now, that killing will continue, and we know this, until something or someone pressures them or applies pressure. So can you tell me why it's always the shortest time frame possible? Why is it like a mad dash to killing when these people snap and they do what they do? Why is it that they're trying to do it in as short a time frame as possible? Until they know, exactly, they know that as soon as the killing starts, someone's going to call for help eventually, and the police are coming. Someone will come to stop them eventually. All right? How do these criminals get notoriety? What is it that makes them notorious besides the fact that they've done this? And what is it about the news account that makes it even more sensational? It's the body count. Yes, if it bleeds, it leads. Yes, and the volume of the body count. That's what they're after. So in the world of mass killers, if you only kill 5 people, well, you'll be forgotten. But if you kill 15 or 20, well, then you're on the Wall of Fame. You know what I mean? That's how sick they are. So they're looking for a body count. They're not looking necessarily to take an hour to find as many people. They know they don't have that much time. They have just a few minutes, okay? So can you name the event that radically changed police response to the active shooter? It's been a while. Columbine. Columbine is what radically changed police response. April 1999, it was 47 minutes before law enforcement countermeasures were applied. 47 minutes. Now, to be clear, I am not criticizing the Columbine Police Department right now. Let's be clear. Because that is exactly what they were trained to do. Law enforcement in 1999 was trained. If someone is inside of a school killing our children, you surround, you make a perimeter, you call SWAT. Okay? And the public outcry to that one Sentinel event changed police tactics forever. And so now it's, if you are an officer with a gun and there are kids being killed inside, or a grocery store, or a school, a library, wherever it is, you go in and you go find the source of hemorrhaging, which is the bad guy, and you eliminate them. That is the paradigm today in modern law enforcement. Okay? It was about 4 hours before the last victim was removed from the scene at Columbine. But to law enforcement's credit, they have changed their tactics radically to meet this new threat. And I am wondering, why has it taken us and EMS and fire so long to change our tactics and to say that, you know, we cannot just wait for police to secure the scene anymore? And that's what we want to talk about today. So there's a couple of general types of active shooter or active violence incidents. There's one that's been spontaneous or near spontaneous. This is someone who truly just kind of snapped. Something happened. They can't take it anymore. And they go out to the car and get a gun or a knife or whatever and start the violence. Because they're spontaneous and not nearly as planned, there's typically fewer casualties. There's typically more targeted casualties. And they're sporadic, so it's not as well orchestrated. Versus the pre-planned ones. Thankfully, these are less common. But when they happen, they tend to be more lethal. Because here, the killer has, in fact, spent days, weeks, months planning it. They brought locks to put around the fire exits to keep people from escaping. They brought secondary devices, pipe bombs, etc., to stop or slow the responding fire and EMS personnel and the police. They brought extra ammunition and more guns, and they set up kill zones. They have pre-planned this out. So they also know that more than likely they're going to die at the scene. So then, if we criticize our medical response, or our EMS response, then should option 1 be, should we change our paradigm now like the police have and say, okay, from now on, if an active shooter happens, we are going to enter the scene saving as many lives as possible? Well, that's kind of suboptimal too, I guess. Option 2 is, well, then do what we've been doing, which is essentially waiting until the scene is declared safe by the police and then proceed in and find the victims. Or how about option 3? Maybe we create a focused, measured response in partnership with law enforcement and minimize loss of life as much as possible. I'm hoping that by the end of our talk that you'll see that option 3 is probably better. In response to the Sandy Hook shootings, a group of stakeholders got together in Hartford, Connecticut, not too far away, and basically, to make a long story short, they got together and tried to form some consensus regarding how do we increase survivability in mass casualty shootings? What can we do to teach people? What priorities can we set forth to maybe minimize loss of life? The Hartford Consensus is known for their work product in the end, which was essentially the THREAT acronym. The THREAT acronym is simply the priorities of medical response in active violence and conveniently enough, not only does it spell threat, but it's also in pretty much the order in which our priorities are. So not only is it the actual what we need to do, but when we need to do it. So when you take those priorities of threat, all these things that we are going to talk about, what we want to do, one of the biggest questions is, okay, well, when? When do we carry out these duties? And the Committee for Tactical Emergency Casualty Care, or CTEC, is a group of civilian and military, actually, but mostly civilian folks who have taken the military concepts of trauma care from COTC. I don't know if you've ever heard of them. The Committee for Tactical Combat Casualty Care, TCCC, the committee referred to as COTC, and taken those principles that we learned from the military and applied it to civilian response. And that's what CTEC does. And by the way, CTEC has done this with the full blessing and knowledge of COTC. In fact, the military has been extremely supportive of this movement because, let's face it, most of what we know in modern trauma management today is from the military. And so the military recognizes this and they say, we're going to help you civilianize this approach to combat casualty care. And that's what this does. So what CTEC has done is broken up phases of care into direct threat care, indirect threat care, and finally casualty evacuation. A direct threat care or hot zone is exactly what it sounds like. You are in a direct threat environment. So if someone walks into your office building and starts shooting right there in the reception area or in the lobby or the front office, wherever it may be, that area, of course, is a direct threat environment. Maybe the back office is an indirect threat until what? Until they move back towards the back offices. Right now, the back offices are a direct threat environment. So as you can see already, these zones are very dynamic. And that's something as a medical provider that you also have to remember when putting a program together, is teaching people that these zones that we talk about are convenient for teaching purposes, but in all practicality, they are very dynamic, meaning they change, and we have to be ready for that. So what I like about this, though, is that you can also apply this to normal pre-hospital care. In my job, I've taken these exact concepts and applied it to my fire departments and my ambulance services to say, you know what? Yes, my protocol says if you have a chest pain patient, you should probably get a 12-lead EKG, and you should probably give them an aspirin if it sounds like an acute coronary syndrome, maybe start an IV. Absolutely. But if your patient is on the side of an interstate highway with 18-wheelers whizzing by at speed and cars whizzing by at 80 miles an hour, is that a direct threat? Absolutely. I've lost a couple of paramedics in the last 20 years to they're on the side of the road treating a patient and got hit. So now my protocols say, if you are in a direct threat environment, please get out of it and proceed off the highway on the off-ramp or a side road or something, and then do your 12-lead EKG and your IV and your aspirin, etc. I mean, do whatever you need to do to stabilize the patient. I get it. But once they're stabilized, get out of the direct threat. And that's something that can be applied, which is cool, to any practice of medicine, especially pre-hospital medicine. Okay? So in a direct threat care, when we talk about shooters, though, the single number one priority is T, threat suppression. Offensive actions to stop the killing. Now, I am not here to comment politically on gun management, gun ownership, gun control, but I will tell you, I don't know if you saw recently, the pharmacist who had a concealed carry, and someone pulled a gun in the pharmacy, and he was able to actually address the threat directly before any of the patrons or he was killed. All right, so I certainly don't expect you to be the ones that carry, all right, but it is what it is. You think about that, okay? But when I'm talking about this officially, I'm talking about when you do call 911, what is the police department's overall goal? It is number one is to find that threat and stop the killing. Okay. Sometimes our military colleagues will say the best medicine is overwhelming firepower. Okay. So stop the source of the hemorrhage. So that's T. The current philosophy, of course, based largely on Columbine, is that we can't wait for SWAT. The very first armed officer must arrive, introduce pressure, directly neutralize the threat or force them to do suicide by cop. I'm sure you've heard that before. Suicide by cop, you know. They know they're going to get killed. They just walk out there with the gun and take it like a man, okay? The first and only objective, though, is to find the threat and stop the killing of innocents. And let me emphasize that officer, when I say officer, it is not meant to refer only to your local police department. At Mallinckrodt Pharmaceuticals, it's such a secure facility, it's a large facility that we actually have a fairly large security force 24/7 as well, and they are armed. If you work in a facility that has security officers, whether they're armed or not, you should definitely include your security staff as part of this discussion with your medical staff, because if someone starts walking into your office with a gun, they're going to be involved. So get them involved early. H, hemorrhage control. Hemorrhage control, I know that we've all learned ABCs is our priority, airway, breathing, circulation. And if you've taken ACLS, of course, in the last 5 years, it's CAB, circulation, airway, breathing. But in ballistic trauma, it has to be XABC. Exsanguinating hemorrhage comes first, then airway, breathing, circulation. And yes, circulation is last, actually, so in ballistic trauma. So when I say X, I mean we've all seen gunshot wounds that were either through and through or not spurting blood everywhere. Those don't need a tourniquet. I'm talking about exsanguination. So someone catches around in the brachial artery, the femoral artery, posterior tibial, whatever, and it's gushing blood. This has to be stopped first and foremost before ABCs even. So the best way to do that is with a commercially made, purpose-built tourniquet. We can make improvised tourniquets, and certainly our colleagues and well-meaning bystanders who did great at the Boston Marathon incident, they made a lot of improvised tourniquets with T-shirts and cravats. But we know that the majority of improvised devices do fail. They may stem the flow a little bit and help, but they ultimately will fail. So commercially built, purpose-built devices are always better than improvised devices. So if you have a budget that you can spend and this is something that you want to make a bag or an active shooter response kit ready, I would highly recommend a commercially made tourniquet. And there are multiple ones out there. You just have to know that the combat application tourniquet, or CAT, is the most common one probably out there. We'll talk about that here in a second. But just knowing how to use it and educating your staff on how to use it will be very important. Don't just buy a bunch of tourniquets and put it in a bag, and then when the day comes, figure out how to use it. I mean, you really do have to train with it. Even though it's simple, you do have to train with it. And this is an example of the CAT. One of the most common error in tourniquet use, I would say, is not going to it soon enough. I know I'm old enough to remember being taught that tourniquets are last resort. Don't put a tourniquet on, you'll cause an amputation. Just do direct pressure first. Well, in a tactical environment, are you going to have time to do direct pressure? Probably not. You know, you want to get the bleeding stopped, and then you want to go move to an indirect threat zone or to move much closer to a safe area. And you're not going to have the ability to focus on just direct pressure, particularly with arterial hemorrhaging. So the point is, just stop the bleeding, the emergency's over, now get to safety. And you can only do that with a tourniquet, really. So I choose the CAT because it's very common. Again, most law enforcement has it. Our brethren in the military have it. And it's important to know that there is actually a wrong and a right way to put these on. The other mistake, once you've actually decided to use it, is thinking that the twisty thing, the rod, does the work, and it does not. When you teach your staff how to use a tourniquet, you got to teach them that it's the strap that does all the work. So if I were rewriting these instructions for myself, I would actually take this until bright red bleeding has stopped. I would actually move that up here to step 2. Because when you put that tourniquet on the extremity and you yank on it and pull it as tight as you can, most of your bleeding should stop just from that. Okay. The other thing is, it's going to hurt. If your victim is awake at all, they're going to scream, ouch, if you're doing it right. And if they're not, you're probably not doing it right. Okay. And they may say, oh, that hurts, stop, take it off. And you all being nice people, and I can tell you're nice people, you look very nice. You would probably want to take it off, right? But you can't. You got to say, I'm sorry, I am saving your life. And yank as hard as you can and get most of that bright red bleeding to stop. The windlass just finishes the work. But don't expect to twist until it stops bleeding. That won't work. And again, our colleagues in the military have taught us from some hard lessons learned that when they investigated the tourniquet failures in the military, it was because the corpsman reports twisting. I twisted it 7 times and it was still bleeding. Well, there's your problem. The strap has to be so tight that you can only turn it once, maybe twice. Certainly no more than 3, but once or twice is all you should be able to turn it. If you make the strap tight enough, then it will be much more likely to succeed as opposed to just twist. Okay. The other thing we teach in the military, which I teach all of my deputies and my officers as well and my medics, is high and tight. We used to say, well, you know, if you got maybe like a radial artery injury or something, then just put the tourniquet up here. But we teach high and tight now. It's high up here. If it's an upper extremity injury, put it up here near the axilla. If it's lower extremity, put it up here near the groin. Because one bone is much easier to squeeze than 2. So rather than trying to compress the radius and ulna and the arteries in between, or the tib and fib in the leg, just compress the humerus or compress the thigh, the femur, and you're good. Now, if I were to ask you, of the upper extremities or lower extremities, which one would you expect, if you were going to have a problem, which one would you expect having a problem achieving hemostasis? If anything. Lower extremity, right? Because there's a lot more meat there. A lot more meat to compress. So something else that we've learned is that you almost never need 2 tourniquets on an upper extremity injury, but a femoral artery, you might actually need 2. And that's okay. So now the question becomes, where do you put the second one? So if one's here on the thigh, you put the other one right here, or next to, almost on top of the first one. Next to, yeah, all right. Next to, almost on top of the first one. Because what you're doing is making a cone of pressure, right? Cone of pressure down to the bleeding vessel. If you put the tourniquet a couple, 3 inches away from the first one, you're just making 2 equally ineffective cones of pressure. So deepen that first one by putting it next to, almost on top of the first one. Whether it's proximal or distal, I don't think it matters. Just put it close and deepen that first cone of pressure. Doing the same exact thing, as tight as you possibly can, and so that you can only twist it maybe once or twice. All right. And then finally, the other teaching point is, when you teach your providers how to do this, is make sure you obliterate the distal pulse. I have had students say, well, the pulsatile bleeding has stopped, and I have a little bit of a pulse still distally, so that's good, so we can still perfuse at least some of the limb. Why is that not good? You're still, yeah, with every beat, you're putting blood in the limb, but it's not getting out. So eventually you will develop a compartment syndrome, eventually. So now that will cause loss of a limb, but not the tourniquet properly applied, properly deployed. Okay. So again, a very simple tool, a simple device, been around for ages. It's been modernized. But it does take about 5 to 10 minutes of directed training to someone to really teach them how to use it to its full potential and its full advantage. So high and tight, strap does the work, obliterate the distal pulse. Most important things. Yeah?
If you don't have a commercial tourniquet handy, what would be your best improvised option?
You know, I have seen people use belts as a great improvised device. Police officers, actually, they sometimes wear a load-bearing harness, and they also carry a baton. There's your windlass. And so I've seen them take their suspenders, so to speak, off, wrap it around somebody, and then take their baton and wrap it around until the bleeding stopped, and that does work too. Now, sure, yeah. So, and you obviously, yeah. And in the military, they issue these tourniquets not just to corpsmen, but to the soldiers. And what's really sad is I once saw a picture of soldiers going out on a mission in a Humvee, and you know what they had loosely tied about their shoulders and legs? Tourniquets. Now, can you imagine the mindset? You're about to do something where putting tourniquets on all 4 of your limbs is probably a good idea. God bless our military people. Question? Yeah.
As you said, it's a cone of pressure, and the one thing that has been studied to look at on animal models and some other surrogate models that just reset for this among the scientific council for the Red Cross on the new filter, new static agents for the new Red Cross guidelines. So, doing the evidence-based. In that question, the main thing you want to take like a simple lesson, make it as wide as possible. So shirts, things like this, that can make broad. Belt, if that's what you got. Certainly don't go forward, don't go correcting. It's very narrow like this. You will never get enough force down
Right.
the vessels, particularly through the thighs.
And of course it cuts, the narrower it is.
The CAT it's hard on the thigh. The average American male, adult male, 190, 200 pounds. Thigh is bigger than my waist. It's hard to get enough pressure down there. You even get a commercial cat set up there.
Right.
Works in the military where they stay lean and lean. Civilian cops.
Now, that's absolutely true. And I was just about to mention that the wider it is, the better load distribution you have, the better cone you can develop. Now, does the name Eric Sterna ring a bell to anybody by chance? It probably doesn't. Eric Sterna. So he was one of the students shot at Virginia Tech, a former Eagle Scout. He realized that he was bleeding to death. And the only thing he had available to him was actually an electrical cord from a lamp plugged in the classroom. And he used that to save his own life. He didn't achieve complete hemostasis, but he got the arterial nature to stop long enough that EMS could get there and put a real tourniquet on there. But he had a partially severed femoral artery, but that's all he had. It was certainly less than ideal, but better than nothing. So, sometimes cops will also say, I can use my bootlaces and stuff like that. But I also tell them, look, if that's all you have, then sure. But those are too thin. You're not going to get a cone of pressure deep enough, and it's going to cut into the skin. So the wider it is, the thicker it is, the better. That's why I like these commercial tourniquets. They are nice and thick and can make a nice cone of pressure. Now, the second phase of care, the indirect threat care, is where we typically start to come in now. And there is some argument whether or not tourniquet should be in the direct threat phase or indirect threat phase. Because if it is in the direct threat zone, you have to have a substantial benefit outweighing a substantial risk. Typically, I see tourniquet placement in the indirect threat zone. Because if I'm in a lobby area where there is a shooter, a gunman at the door, and my colleague is bleeding, I'm not going to apply a tourniquet there, right, in a direct threat environment. I'm going to pull them away, get them out, or get them to safety somehow, and then try to do hemostatic control. Yes?
So I've looked at part of the Hartford consensus from the public health perspective, and I'm interested, the gentleman who's working on the guidelines from Red Cross is still here. Because part of that consensus is the see something, do something part, which is this teaching the public something to do. It's interesting that the Eagle Scout was able to save his life because even when most first aid courses had stopped teaching anything about hemostasis, the Boy Scouts first aid course, because of its wilderness focus, had continued that in their curriculum. And so, I don't know if you were going to talk about teaching that hemostasis as a public response.
Oh, absolutely is. That's a whole different talk. In fact, but now that you bring it up, I will mention quickly that the CDC has initiated a campaign. I'm sure you've probably heard of it by now. Stop the Bleed campaign. Dr. Richard Hunt out of the CDC Office of National Preparedness has launched this initiative where we now have AEDs, right, that are ubiquitous. They're everywhere. Grocery stores, schools, airports. What the Stop the Bleed campaign wants to do is actually put hemorrhage control kits underneath every AED. So wherever there's an AED, you have a little bag that has 5 tourniquets in it, 5 pressure dressings in it. So again, the thought being that it contributes to public resiliency, but it absolutely becomes a public health problem. And if you look at it that way and you prepare for it, instead of saying, well, we're just going to wait till EMS arrives, which could be a while, that's not optimal. So yes, that's a very good point. Hemorrhage control is now being looked at as a public health initiative, and we need to teach the public how to use a tourniquet, when to use a tourniquet, and actually make it available like fire extinguishers and AEDs.
And back to those found or improvised opportunities when there's nothing else.
When there's nothing else. Yeah, when there's nothing else. But again, because we know that the improvised ones don't work as well, what the CDC wants to do is make it available everywhere like AEDs and fire extinguishers so that you don't have to improvise them. A great point. So now that you've gotten to an indirect threat care environment, now we can start, if we haven't already, take care of exsanguinating hemorrhage, like we just mentioned, X. But now think about ABCs, airway, breathing, circulation. Typically, especially when we have mass casualties, we are not going to be able to be intubating 15 people or doing advanced airways. We do basic triage maneuvers, which is basic airway maneuver, right? Head tilt, chin lift, something. If they breathe, great, they're a red. If they're not, what do? They have to be expectant. And we move on to the next victim. Okay? B, breathing. Either needle decompression for a tension pneumothorax or chest seals if they have a sucking chest wound. And remember, a chest wound doesn't have to be that big to be a sucking chest wound. It only has to be about 2/3 the diameter of the trachea, which is not too big to be a sucking chest wound for air to want to go in the chest instead of your mouth and nose. So put an occlusive dressing on there, even a gloved hand momentarily so that the patient can breathe again. And then circulation is going to be a very limited role, right, for IV fluids. Even if you have IV capabilities in your dispensary, your infirmary, your clinic, you're probably not going to be starting a bunch of IVs on people. There's going to be a limited role anyway for IV fluids. Remembering that if you are in indirect threat care zone now, the zones are still very dynamic. So you have to know where is the shooter, where is the criminal who's committing active violence, and where can I be, where can my staff be to be relatively safe anyway. When you do this training and you discuss with your staff, okay, where will we go, what are our priorities of care, how do we provide this care, remember we don't do it in a vacuum. We are going, if your facility does have security, they're going to have to be involved in this, and if you don't, even more reason to get your local police departments involved early on, to train with you, to give you some advice as well, and to say, what are some relative safe areas that we could make or harden up in our facility? And then maybe in those areas of refuge, we can put active shooter bags or bags that have hemorrhage control, hemostatic agents, tourniquets, what have you, for that possibility. Another question that I get a lot, because this is actually what I do mostly with the police department, is, well, do we really have to do all this training? Because doesn't SWAT have tactical medics? And the answer is yes. Most modern SWAT teams now do have tactical medics or tactical physicians on their team. But how long does the typical active shooter incident last? It's not very long, right? 5 or 10 minutes, less. What is, on a good day, how long does it take for a SWAT team, once the pagers go off, to mobilize, gear up, get their orders from their commanding officer, and go do an assignment? On a good day. 45 minutes, an hour. So this is not a SWAT problem. This is your problem and a patrol officer problem, but it's not SWAT's problem. So no, we cannot depend on tactical medics to mitigate this situation. We have to do it because we're the medical people for our facilities. So we have to do it. Okay. This is not to say, and I want to emphasize, that we can't teach our medics or our medical staff how to use tactics. So tactical medics is not the same thing as medics using tactics. We can all learn tactics, which is what I'm trying to teach you today. Some basic tactics will go a long way in mitigating this kind of an incident. So teaching your staff, teaching your medics some basic tactics. That's what I'm talking about, not necessarily tactical medicine. Moving on to RE, rapid extrication. So rapid extrication to safety. One of the things, and this actually, in order to be truly the most helpful, a casualty collection point or CCP might actually be in an indirect threat care zone, not in a cold zone. Okay? Because if you're in a cold zone, where should you be going? The hospital. Okay? You should be going to the hospital. So I'm talking, again, using my facility example at Mallinckrodt Pharmaceuticals. It's a huge facility, multiple buildings. In the drill that we did, we simulated that someone jumped the back security fence and started shooting workers through one of the first compound buildings that's on the premises. We actually used an adjacent building as our casualty collection point because we said, okay, we've got lots of victims here. Security is chasing the sound of gunfire on the other side of the plant, but we've got 10 people down here. What can we do? Well, we only have one medic and maybe half a dozen responders, first responders at any one time. So to concentrate those resources, instead of taking the one medic to 15 people, we should try to bring the 15 people to them, and they can start rapidly triaging and doing things. And so we had this adjacent building, a little conference area, and we just moved the tables and chairs, and that was our CCP, our casualty collection point, until we could get them out of the plant. And remember, our plant is locked down. You can't get in or out until security lets you in. It's a secure facility. So even if you call 911, the fire department can't just come in. They've got to be escorted. Security has to let them in. It's delayed somewhat. Okay, and I'm guessing that your facilities, your offices probably have key card access or something that the public just can't just wander through your facility. At least I hope not. So if you remember that a CCP is a function of several things, one of them is the number of patients. So if you only, quote unquote, only have 3 patients, but you've got yourself and a nurse and a medic, maybe you're not overwhelmed. But if you have 10 or 15, then you are. And now a CCP may actually help focus some of those resources. Okay. It's also a function of time and distance in addition to the number of casualties. So if you have a relatively small office and it's right next to a good egress point and police are there and they've surrounded the area and you can get your patients off to the hospital, then great. But if you have a large facility, it's going to take half a football field to get to the exit point, to a staging area. You might want to consider a CCP again. Yeah.
What do you recommend or what is done in this company regarding how to initiate the call?
The call to police?
Initiate the response.
Oh, okay, sure. Good question. We have a horn system. So I know it's antiquated, but it works. So I think 3 horns means fire, 4 horns means a medical problem, 5 is a tornado, a weather emergency. So each series of horns will blast throughout the plant, and you can actually hear it across half of St. Louis as well. Air horns that blast, and kind of tells you that there's a problem. Simultaneously over the radio, and all the supervisors and key staff have portable radios they carry around. So security officer will declare what's going on. So the minute you hear the horn sounding, everyone will listen to their radios and say, okay, there's a chemical leak in building 250, or there's a medical emergency in building 94, or there's a shooter in the back campus, or something to let us know what's going on. At the same time, security will be initiating that call to 911. Did that answer your question? Okay. Yeah.
You have forgotten one other thing.
Yeah.
That is social media. We had a situation at our plant, and you have to consider that like everybody in the plant has a cell phone.
Yeah.
And guess what
Text messages.
Cell phone, Facebook, and this and that. And so it's out there too.
Our hospital actually uses that to their advantage. They can instantly send out a mass alert to everyone's pager, cell phone, email account, and a message just like that. So yes, you can use that. At our plant, we also have closed circuit television that they can flash messages up on the closed circuit television. But that's a good idea. I should go back and ask them about, hey, what about Facebook? Or I don't even know if we have a Facebook page. Pardon me?
It's also a bad one too.
Yeah.
Because
Yeah.
it can get to the wrong end.
Sure.
Out there.
Sure. It can.
Media
Yeah, absolutely.
can monitor that.
They absolutely can. Yeah, very good point. There is a little bit of nomenclature that you should also be aware of when talking with your police agency, secure and safe. So at the Aurora, Colorado theater shootings, for example, the police were able to relatively quickly make the lobby area of that theater relatively safe, meaning to bring responders in and start triaging people. But it's not secure. So when police say a building is secure, they mean that they have gone through and done a secondary search. So they have lifted the rafters off of the drop ceiling. They've looked underneath every chair. They've done everything to look, and there's no other threat. That's secure, okay? Versus safe. You can make something relatively safe, but not yet secure. So if you're in a CCP, and for our drill, for example, we had an armed security officer with us. We were in a safe area, but it wasn't necessarily secure yet. So what we're trying to say is that I think we have an obligation as medical providers that while people are dying and bleeding to death, we cannot wait till things are secure. But we can certainly partner up with security and police to make things safe so that we can reasonably do our job and do some medical interventions. Assessment of injuries and stabilization. Recheck those tourniquets, recheck your airways, make sure your patient is not developing a tension pneumothorax, because that's one of the ironic complications of occlusive dressing is development of a tension pneumo. So make sure that you don't have to address that. And think about if you do have access to IV fluids, that you are not going to do what we used to teach paramedics 20 years ago, which is 2 large bore IVs and 2 liters of crystalloid, make their blood pressure normal. We used to teach that. Horrible. Because we know that that's not the best. This concept of permissive hypotension is not to make the blood pressure low, rather that if their blood pressure is low but they are mentating okay, we don't necessarily have to flood them and make their blood pressure normal to make us feel better. It makes us feel better, but it's not what the patient needs. Because what we're doing is we are simply wanting to maintain perfusion, but what we don't want to do is pop that proverbial clot, right? If they're starting to form clot, and then we make their BP 120 all of a sudden systolic, and we pop that off, that's not good either. Or we contribute to their coagulopathy by diluting out their proteins and their clotting factors and their oxygen carrying capacity, frankly. So, again, totally stolen concept from the military. One of the things we have to think about, though, is in the military, they're usually lean and mean, younger, right? Versus the average age on my plant is 54 years old, which, by the way, is quite young. Yes, there you go. Guard reserves. 54 is quite young, and we just make sure that we don't want to contribute to acidosis and coagulopathy and the like. So it avoids that cyclic over-resuscitation that leads to rebleeding and exacerbates hypotension in spite of increasing crystalloid development. Okay. So Forrest Gump says, "I'm not a smart man, but too much saline seems like a bad idea in penetrating trauma," and it is. And I'm ashamed that I used to teach that to my medics years and years ago. 2 large bore IVs, 2 liters of crystalloid before you get to the ER, or you're a no good medic. So Now they know better. Now we know better. Okay. So again, low blood pressure is not the goal, but rather, if we can get hemorrhage control, that is our goal. Once we get hemorrhage control achieved, then maybe we can start thinking about normalizing the hemodynamic status a little bit more. Whenever I do this training, though, with my medics and with my occupational medicine staff on the plant, something that I always try to remind them, and frankly, I have to remind my own emergency medicine residents of the same thing, is that when you get a patient with penetrating trauma and their blood pressure is 80, the first and often only thing they can think of is hemorrhage. But I have to remind them, hey, there are a couple other very important things that you cannot blinder on and forget. And especially in penetrating trauma, so tension pneumo is one, and tamponade physiology is the other. So depending on what group I'm talking to, of course, we'll then go into management of that, pericardiocentesis, things like that. But rather, the signs and symptoms, Beck's triad, all those other things that we learned that helps us to differentiate between tension pneumothorax and tamponade physiology, and just not forgetting that. That's all. So when you go back to your facilities, and hopefully you find that this is something you probably should do, when you make your program out, just make sure that you include these other things that can be seen, just so that it's not left out. A word about permissive hypotension, because every time I also talk about this, someone will remind me if I don't say it first. Yeah, but that's not appropriate for the head-injured patient, and that's absolutely true. So if you think that their primary problem or significant part of their problem is brain trauma, then permissive hypotension is probably not good, right? Because they need that cerebral perfusion pressure, and they kind of need that blood pressure. So as usual, it's kind of a toss-up. It's kind of a balancing act that you're going to have to decide on at the moment with the information that you have. Does my patient need permissive hypotension more than they need cerebral perfusion pressure? Or do they need the cerebral perfusion pressure more than the risk of coagulopathy or clot? So weigh that as well, as if your job wasn't hard enough in one of these situations. Remember to think about that too, if you're deciding to use permissive hypotension. Finally, the last T in the THREAT acronym, transport to definitive medical care. And again, as luck would have it, it's pretty much in the order in which we need to do things as well. This is now in the cold zone or casualty evacuation or CASEVAC phase of care. The casualty evacuation phase of care implies that you are now in a no-threat environment, that it is the cold zone. It is a secure area. This is where our ambulances will go. We certainly try not to put our ambulances into a warm zone because, again, it can become a hot zone very quickly. But we do staging and staging officers and transport officers, at least on the civilian side. We really try to make this a secure area and a cold zone as much as possible, which means that sometimes there's a little bit of a trek between the casualty collection point and the staging area where the cold zone may be. And this is, I got to tell you, this is one of the areas that we had the most information sharing with our police departments when we train with them, is that they have to understand where we're coming from as much as we have to understand their priorities of safety. How can we establish, if it's not secure yet, how can we make at least a 50-yard corridor where it's reasonably safe that we can start exfilling these casualties out of our makeshift CCP to the ambulances so they can GO go? And that was a very eye-opening conversation with law enforcement. And we both learned from each other. And I think you will do the same if you go back to your home agencies. It's really interesting. But lesson learned is that you have to talk about it before it happens. Otherwise, it's really going to be chaos. Not that it won't be already. But it will be less so if you at least pre-plan and talk to them about this first. And from the medical staff standpoint, I'll tell you, whenever I provide these concepts, about 80% of my firefighters and paramedics are like, heck yeah, it's about time. We're sick and tired of waiting, knowing people are dying in there. We need to go in with the cops and help these people, which is great. About 10% of them are like, I got to think about this a little bit more. I signed up to be a fire paramedic, not get shot at. Why are you giving me this bulletproof vest to wear? And why does it say fire on it? How about not fire? Seriously, we bought our firefighters red bulletproof vests. And it said, police say police on it, the fire says fire on it. One smart aleck took some white surgical tape, put not, and right over the patch, so it says not fire. Yeah, do not fire. But then I have 10%, the remaining 10% who will say, I want nothing to do with this. I didn't sign up for this. I'm not interested in going into the warm zone, no matter how safe you make it. Not for me. And that's okay, because we need people in all three zones. Not everyone can be in the hot zone or vice versa, the warm zone or vice versa. So for them, I say, that's fine. You still have a role to play in the casualty evacuation zone, but just because the patient gets to you there doesn't mean you don't have anything to do. A lot of bad things can happen between the CCP and you in the back of an ambulance. So you really do have to understand that even though there are no hostile threats and you're in a secure transport staging area, you still need to reevaluate the patient, reassess the tourniquet, airway, breathing, circulation all over again, en route, preferably, not on the scene, and get going to a hospital as fast as you can. So there's a role for everybody. There really is. Question?
Has there been any thought about, we're with the resistance to, limit use of the availability of handguns and so forth in our society, and we know this is going to happen again and again and again, and when we know that as rapid a response as possible is what probably will make a difference, I would think. Has there been any thought about just general super basic education for the everyday worker, such that they know some very basic things to do in these circumstances? Because they're the ones that are probably in the best position to put on a tourniquet rapidly than waiting 10 minutes.
You're dying to say something, aren't you?
I got to be on the scientific council or scientific advisory council of the Red Cross sideways by having been asked by ACOEM to be their representative at ILCOR for reviewing the 5-year update on ILCOR. And from that got me to being on the scientific council for Red Cross. So I sort of take it as I am there as your agent. Red Cross is a business. Profit business, but it's a business. They, like others, sell first aid courses. Anybody here who would like to ask your employees to take Red Cross first aid courses, those courses will have in them evidence-based guidance for this. We are, at the moment, working on going from the Hartford Consensus. The Hartford Consensus came together, as you heard, from surgeons, the American College of Surgeons Committee on Trauma, came together and invited in some other voices to come together and look for training and guidance for professional responders. We based our guidance for the lay Red Cross and the paperwork that I did, working off of their scientific reviews on both, primarily on tourniquets and hemostatic agents. But coupled with that is now the algorithm for how do you do this, how do you apply, and what do you decide. By far and away, as he said, pressure is a pressure. These things, the rapid return, that rapid use of tourniquets, rapid response to the rapid turning to hemostatic agents, powders, or impregnated bandages, and so on, has great data on a population basis out of the military. Good information from pigs where you make wounds in their bodies and you use tourniquets or you use the hemostatic agents. So doing it in the model, you can't do it in humans. But the population data out of the military, doing this business of getting every military guy on the ground a tourniquet and saying, don't call for the medic and get him frickin' shot. Take care of yourself and get covered. Let the other guys deliver the medicine to the other side. That medicine is called lead. Let them deliver as much lead as they can to the other side, and that will save you. You got to do what you can to save yourselves. You trained how to put this thing on, blah, blah, blah. Once they did this, the military saw the drop in deaths from exsanguinating extremity hemorrhage plummet during the Iraq activities.
So
The sad positive sides of war, that you have large numbers of population that can work on certain issues.
So the Hartford consensus recommendations from their consensus for beginning to create this public initiative are in a document that you can find on the web. Hartford consensus, and then it's see something, do something. That's their intended perspective to get at exactly what you were asking about, which is what do we start teaching the public to do, just like we teach public responder CPR. We need to begin to reintegrate these very basic kinds of first aid skills that we took out of first aid when I was in 7th grade.
Well, we didn't just take out first aid, but I think looking around the room, I see probably a few people that are old enough to remember when bomb shelters and civil defense and all that stuff was a part of our elementary school lives, and first aid was something that everybody did, whether you were a Boy Scout or not, if you were a Girl Scout. It was just a part of being a good citizen, and it's gone. It's been taken away and professionalized. Well, it is, but professionalized by our professional caregivers. So it's sliced at a paper cut and they call it EMS because they don't know what the heck to do.
Right.
And we've taken it away, which is fine at one level, but the EMS is now also trying to give it back to you because they're spending time and money and resources on unnecessary calls. Once again, whether it's student record, I count the Red Cross, because again, I'm your agent there, and I think they do very good work at doing this business of evidence-based reviewing of these kinds of guidelines to go into their training products. It is a product, so I have to say I don't want to sell just their product, because it's also this Hartford consensus concept all over. Hartford consensus, once again, was focused originally on professional responders, and the review that they had done through MITSA that was done by a private consulting company in Beltway that does research things, was done with a view on professional responders. And then there's once again this whole business of if you're in the hot zone or if you're under risk, that's again the idea where you ramp up the first response like the Tourniquet as opposed to really the first response in most situations. Pressure do it for 99.9% of wounds if enough of it's applied. That's been shown in the research studies as well, particularly the ones around the hemostatic agents. When you take something like Perlex and stick it in the same wound versus a hemostatic agent, you get the same results. But if you're in the field and under fire and you maybe can't keep that pressure on it, you can just throw something in the wound, wrap a bandage around it to hold it on, hike it up as tight as you can, and start shooting back. It's a whole different world in these kind of situations that you're in. So part of my message is don't take this as this is the general response. Everybody running out. I carry a tourniquet with me. I carry a cap in my backpack all the time. It's like a CPR mask. If I can't do this in the pressure, if there's any situation I come upon where I can't, either I need my hands for something else. It's not just active shooter. If you've got 3 people who are injured, or you've got other things you've got to do, get this person out of a burning car or whatever, something, who knows what it is, if you need your hands for something else, this becomes an extra hand. I don't carry hemostatic agents, but we're still reviewing those and verdicts out on those, bulky and so on. So, sorry for the long tirade, but the real answer is it will be soon, and there probably already are by a variety of vendors, courses out there on first aid for your employees that will have this kind of teaching.
And I think that's exactly what the CDC Stop the Bleed campaign is aiming to do. Contribute to the public resiliency again. Return this responsibility back to be a good citizen and not to lay there bleeding to death waiting for someone to come help you. I like that message very much, and I think it's going to take hold.
One other thing to say to that was that you said it up front here somewhere where there was, I don't know if it was your question, but it was the getting people to do this and getting them to do it, not just to sit in the class and look at a bunch of slides. People do that and it's very well shown that they still freeze when it happens. I don't know until they've actually had their hands on something, even if it's just a tell me up front. Once somebody's done a mini scenario and said, Joe, what are you going to do now? You know, the guy's down, he's bleeding. Come on, Joe, don't tell me, Joe. You get down on your knees, shoulder over, and just look like doing CPR. And that's where most of these
Yep.
things come from, is looking at will these people really engage. The people who have actually gone through the psychomotor memory systems really in making that initial surge are the people who work so hard.
Yes.
When you were doing your planning for the city,
Yeah.
and you were going through your echelons or your stages, what did you plan in the city for when Barnes became the emergency room became the hot zone?
If
I mean, because
no,
it's
no,
not
you're right.
possible, so,
If the ER is the hot zone,
yeah.
then that's a really bad day. That's a really bad day. What we have done is we have not only simulated, but we've also practiced making the cafeteria, which is one floor up from us, as our ER. So patients would be moved up there, or we would, if we could, evacuate people up there and use that as our ER, so to speak, because it's very large. It's got a lot of electrical receptacles for pumps and vents and stuff like that. But in a widespread, if you're talking about a Paris-style or Mumbai-style attack, that's very difficult to defend against. And I'm not sure what we could do from that point. But a single person walking through the campus and we need to go on lockdown and move patients up, that's where we would go. It's the only place in the hospital where we could go. We have 70 beds plus 10 other spaces. There's no place else we could go but the cafeteria, which is huge. But we have that in the plans, yeah. Probably not, I don't know if it's the best, I don't know if it's the optimal, but that's the only option that we really have. Yeah. Excellent comments. Any others? So when I introduced the concept and the last concept of the cold zone, I remind them that whether you're the medical provider, whether you're the physician or the medic that's there by choice or because that's all that was left, don't assume that everything was done already just because they've already been treated. Make sure you double-check everything. Double-check everything. Okay. Now it's time for you. You've already been very interactive, and I love that. Now it's time for you to be even more interactive. You make the call. Many years ago, they used to do this in Monday Night Football. Some of you remember this, right? They would show a play, and then you'd have to decide, was that really a touchdown or not? Well, I don't know. You make the call. I did this to a group of folks once, and one youngster in the room said, what's IBM? I almost slapped him. I said, IBM, you know, they used to make typewriters. What's a typewriter? So, shots are fired within your office building, and you see a worker maybe 20 yards away on the ground. There's profuse bleeding from the popliteal artery area, and he can't move and screaming for help. Cover is maybe 5 yards behind him. Okay. You make the call. You should. What should you do? What are your priorities now? What's running through your mind after all we've talked about so far?
Stop the bleeding.
Okay, so stop the bleeding. Are you going to run out? Okay, there's another good question. Where is the shooter, right? Because that determines are they in a hot zone or not. Was it like bang, bang, and they ran out somewhere, or was it bang, bang, and they keep going, bang, bang, they're still walking towards you? That's very different, right? So, sure, where is the shooter? Where's my threat? So what zone are they in? What else do you think about? What? Absolutely, call 911. What else? What else are you thinking? I heard stop the bleeding. Now you're talking. So what clue in there gives you an idea of where that can be? Cover is about 5 yards behind him. So what's the difference between cover and concealment? Not the military guy, because you know this. What's the difference between cover and concealment? Good. So cover is ballistic protection. Concealment is just hiding. Okay. So shower curtain, great concealment, lousy cover. Okay. Okay. Yeah. Huh? Yes, so cover gives you ballistic protection, but concealment is just hiding you. So shower curtain, concealment, no cover. Okay? Bulletproof glass, great cover, lousy concealment. So ideally you have both cover and concealment. Okay? So if say he goes down in the parking lot of your facility, there's a big, you know, those big brick structures that have the dumpsters. Hey, he may not even realize the cover is behind him 5 yards behind him. Say, right behind you, cover, get behind the dumpster. And he can shimmy back there, and you can now walk him through self-aid and buddy aid. You know, take your belt off and wrap that around your leg or whatever. Help them out. What? He can't move, and he's screaming. Well, there you go. So, but you know, do some remote assessment. Can he at least use the other leg and shimmy behind him 5 yards, maybe? Profuse bleeding. So you want to try to get that bleeding stopped if at all possible. Absolutely. Know what your zones of care are. Where is the threat? Maybe you can help them get the cover. Maybe you can help them fashion a tourniquet, or if you don't have one. Well, what are some, at least for now, what are some reassuring things about this case that makes you? He is screaming for help. Airway is open. Breathing is pretty good so far. Circulation is good because he's mentating enough to know that he needs help. He's screaming for help. So the mental status, clearly, it's not like he's obtunded and bleeding out. Now the stakes have ramped up even more. Okay. So all of those things put together, you have to consider. So good. That's a possible or potential scenario you can make. How about this one? 3 workers are shot, and there are only 2 first responders and 1 medic on the scene. You lock down the area that you're in, and you're relatively safe. I should say, not secure. Relatively safe. Victim 1 is not breathing. There appears to be brain matter coming from the head, and there's no pulse. Victim 2 is awake. Moderate bleeding and pain from an abdominal wound. They're pale, sweaty, diaphoretic. Victim 3, heavy amount of bleeding from the brachial artery at the bicep area. So you make the call. You should go to the worst one first, right? Which is obviously victim 1. No? You're heartless. All of you, heartless. So you would do 3 and then 2? I think I could agree with you. Because, yeah, unfortunately, penetrating trauma plus no signs of life equals less than 0.1% chance for survival. So in the triage scheme of things, and if there's 5 physicians and 5 nurses and 5, great, go to victim 1. But then everyone else can go to 2 and 3. But, you know, in this situation, we're talking about triaging. So sadly, 1 is probably not salvageable. I would do 3 first because they have what? Exsanguinate hemorrhage. Get to them first. Get a tourniquet high and tight, stop the bleeding. Make sure you obliterate the distal pulse. Make sure that the strap does most of that work. Second, victim 2, they're going to be pretty sick, right? They probably have an abdominal wound. They probably need an X-lap. They're sweaty, diaphoretic, so you're worried about internal bleeding and a shock state already. So they are also a very bright red as well as far as triage category goes. I would actually venture to say that if in fact the only wound that 3 has is the brachial artery wound, and you've got good hemostasis with the tourniquet, they become almost a yellow, right? I mean, almost. I mean, if you now are trapped inside, and a police officer says, "Okay, we got time to take 1 person out of here. Who's it going to be? 3 or 2?" I would take 2. 2 needs an X-lap very, very fast. The emergency is essentially over for 3. Will 3 need surgery eventually? Yeah. Probably, but not now. You know, the victim 2 will need surgery 5 minutes ago. You know, so I would triage 2 out of the CCP first, and then 3, and then unfortunately 1 is going to be an ME case. Preserve the evidence, though. Don't do a lot to them. So good. So one of the excellent concepts brought out by you guys already was this concept of resiliency. And what are we doing to teach other people what to do in these kind of situations? One of the things I did at the regional meeting, CSOEMA, and at our plant drill where this all started in 2013 was this part, which is, look, we talked about the medical stuff and how to treat people, but you also need to think about what do you do if you are caught, you're not at work, say you're at the grocery store, you're in the pharmacy, you're at the library, whatever, and this happens to you. Well, you know, there are quite a number of resources out there, particularly online. Homeland Security actually has a video series out there. They have these printable cards that you can print out as well. And I'm on my handout that I'm going to pass. In fact, I'll just do that right now. I hope I have enough, but take one and pass it out. I put it on the front page. And it has these things where it reminds you, if at all possible, if you can, leave the area. So evacuate. You know, get out of there. If you happen to be running into law enforcement who's responding, you certainly don't want to be running out of the building with your hands in your pocket. Get your hands out. Let them, because they don't know who you are. So make sure your hands are visible. Get out. All right. If you can't escape, at least hide. Remember what we said early on, that they're looking for a body count. So they're looking for targets of opportunity. They're not, if they open a room and there's no one in the room, they're going to keep going and looking for victims to kill. They're not going to say, oh, there's no one here. And they're going to come back here, then look over here, and look under the table. They're not looking at the table, okay? So, I mean, quite literally, if you can hide underneath the table, that's all you can. That is better than being out in the open. So hide out, block entry. The worst thing that you could do is be safely hiding on the table and your cell phone goes off. So silence your pager or phone. You know, that's bad. You thought it was bad in the movie theater. Yeah. Turning off the lights is another good one because they think that no one's in here at all. So, yeah.
So after Columbine, I know for my high school, they had like mock SWAT drills after all the high school shootings. But back then, they used to tell you that because all the doors were bulletproof at that point in the glass, but they told you to still lay on the ground, even if there's like 30 people in the room.
Yeah.
Is that still the case? Because I mean, I shot a Glock, and a Glock would penetrate that wall.
Yeah, that is right. No, that's not bad advice at all.
So I mean, is that still the
Yeah.
thing? Like if you are in a room and you can't hide?
Yeah, and that's a good point because this wall is actually probably concealment, but a bullet will go through it into the next room. Certainly through that partition, it'll go right through it. It's not cover. So yeah, I mean, if you are in a room and especially if there's potential, if there's still active shooting going on, which is true for any ballistic situation, keeping a low profile, being as low as possible is always a good idea.
So none of them have started to do this number. They're still just doing this number.
As far as I know. I don't know that there's any studies out there looking at that, but it certainly seems it certainly seems logical that you would just be low to the ground. And then finally, take action only as a last resort. You know, we certainly don't expect you, unless you are yourself an armed officer, to go to the sound of the shooting. But only if, as a last resort, you're faced with the criminal. There's nothing else you can do. You certainly don't just want to stand there, but you want to take action and do something about it. One of the training series that they put out that Homeland Security does is Run, Hide, Fight. I'm sure you've heard of that before. Run. If there's an escape path, evacuate. Warn other people. So if you're running out of a building because someone's shooting inside and people are walking in, you probably don't want to be, do your fellow human beings a favor and say, you probably don't want to go in there and leave. Don't stop to retrieve your belongings and everything. Get out of there. Hide behind large objects. I've always thought that was funny, but yeah, you should. You should hide behind large objects. Silence your phone. Be very quiet. Blockade the door. Keep low. And then, of course, last resort, fight. And again, because all of you look like extremely nice people, and you could never gouge someone's eyes out with your thumb, you might actually have to do something like that. That's why it says commit to your actions. You cannot be like, it's going to be, you really have to hit somebody and be quite forceful and commit to your actions and act with aggression and yell and scream. Because these active shooters, are they expecting people to come after them? No, they're expecting people to cower and scream and cry and run. They are not expecting anyone to come at them with a pair of scissors or to come after them with a coffee mug. That's exactly what John Hessel did. So John Hessel is a local councilman in St. Louis. He was at the Kirkwood City Hall shootings. This happened many years ago. But a disgruntled citizen walked into City Hall during a council meeting and started shooting up the place. And John Hessel was face-to-face with this guy. He picked up some coffee mugs and chairs and stuff, and he threw it at him and screamed and kept moving. He was not a stationary target. He kept moving around the chairs in City Hall. It was much like this room is set up, but instead of standing one place, he would move this way and throw stuff at him, and then he'd move another way and throw stuff at him. So he was constantly moving. He did get shot, but no fatal wounds. And the difference was because he kept moving and he fought back. He was very aggressive. He threw chairs and coffee mugs and pencils and pads of paper and anything else he could get his hands on. He bought himself just enough time for Kirkwood police to enter the room and neutralize the threat. But it was just enough time that he bought himself to do that. So run, hide, fight. Another common one that you can learn easily, that you could easily teach your staff, is ALICE. ALICE stands for alert, which can be anything, whether it is a PA announcement, a phone alert, social media notice that something's happening, the gunfire you hear yourself. That is your first indication that there's a problem, right? You can't act until you know that there's a problem. And I don't know if you saw this, but in San Bernardino, at the San Bernardino shooting, there was footage of a lady's cell phone video that she was taking of the whole thing because she thought it was what? She thought it was a drill. She thought it was a drill. So gunfire, she thought it was a drill. She had no idea it was a real thing. So be alert. Consider in this day and age that anything like that can't possibly be a drill unless it's well publicized. And I'll tell you, kind of along those lines, when our SWAT team does active shooter drills, we have sandwich boards placed all around the parking lots and everywhere. This is a drill. This is a drill. And we have people wearing bright orange vests so that's kind of clear that people are watching this and stuff like that. So be alert. It can be anything. The L stands for lockdown. If you can't evacuate, then, of course, make a semi-secure starting point from which you can barricade yourself or cover the windows, silence your cell phones, gather weapons, prepare to defend yourself if you have to. I is inform, using any means necessary in plain language, by phone, Morse code, whatever, that there's a problem. Try to give the specifics, who, what, when, where, how. C, counterattack. This is the useful use of simple proactive techniques, again, to defend yourself if you are confronted by the active shooter, being, again, committing to your actions and fighting back dirty if you have to. And finally, of course, E, if you cannot have done that first, try to make preparations or look for opportunities to evacuate as soon as possible. This is a screenshot from the Columbine school shooting where a student finally found a second-story window and went out that way. They used an improvised rope made out of belts and other things and tried to lower themselves at least somewhat to the ground. And again, if you are running, you don't want to just run in a straight line because from their vantage point, you're standing still. So lateral movements helps make yourself be a more difficult target to hit. Okay. So when you put all this together, whether it be run, hide, fight, I'm hoping now that as medical professionals, you're seeing that there is some value now in adding the fourth component, which is treat. So run, hide, fight, and treat. Because people will expect us, because they know we're medical people, to do something with the bleeding, with the people who are injured, who are not bleeding, not breathing. When the police do respond and come in, remember that they don't know who you are. They're not going to assume who you are either. So be prepared to lay out prone and be treated like a criminal. It's not, don't take it personally or be offended. They're going to pat you down too, probably, until they know who everyone is. It's for your own safety and theirs. But be calm and follow their orders exactly. One of the other things that they will do is probably bypass anyone who's injured, anyone who's on the ground and bleeding. Even though they're asking for help, you might be asking them for help. Their number one priority is to find the source of hemorrhaging. And as was mentioned, give them lead poisoning. Find the shooter and eliminate that threat. So don't be offended by that either. They're just trying to stop the hemorrhaging. Then they'll circle back and help you. But only after the shooter is stopped will they begin to provide assistance. And that's how they're trained. That's actually what they should be doing. Okay. Now, there may be actually two different types of police teams that come in. One is a contact team. The other is a rescue team. The contact team is the one who's going to go in and make contact with the shooter. They're going to bypass all other people and things and cries for help until they find that shooter. Behind them now, police are beginning to develop what are called the rescue teams. This is where 4 cops, guns drawn, will take 2 medics in the middle and start finding victims. And they're going to start helping you with these victims that you have designated and triaged that hey, this one's hurt worse. They have to go first. That's when they're going to start helping, but only if they're on a rescue team. This contact team is going to go right by you. Certainly, if you do come into possession of a weapon, please don't think you're helpful and say, here's the shooter's gun, because you'll get shot first before your first words are out of your mouth. Leave it. Don't brandish it. You can secure to have someone post on it, but don't touch it and just let the police know where it is. Other things that you can think about for putting together an active shooter medical response bag besides a handful of tourniquets and pressure dressings, other hemostatic agents, other improvised bandages even, things like tampons and feminine napkins actually can expand quite quickly and help to provide pressure for blood loss. That's also something you can do. The shoelaces and belts we talked about as improvised tourniquets, although not ideal, better than nothing if you don't have a commercially available tourniquet. But be prepared to think outside that proverbial box and use anything you need to do exsanguinating hemorrhage control, airway, breathing, circulation support. One of the lessons learned, and I do encourage you to actually drill, because I totally agree with what was said just now. It has to move beyond boardroom discussions and tabletop exercises. You've got to do this. And one of the most valuable drills we did on the plant was forcing everybody to actually manage victims laying in our back parking lot from simulated gunshot wounds. And instead of saying, okay, now I would take them over there, really, take them over there. How are you going to do that? And that opened a whole new discussion about lifts and carry techniques. How do we do a one-man lift, two-man lift, fireman's carry, military drag? I mean, how do we do this? And do we use litters or not? And what are the pros and cons of that? But remember how I said that we had our relative safe area in that building next to where all the people were shot? And we had an armed guard with us? Well, guess what? Over the radio, his colleagues were saying in the exercise, we got more shots fired in building such and such. He left. He left us. So in the after action report, it was made very clear, you can't leave us. You're our security. And he didn't mean to do that. He just got caught up in the moment, and his colleagues are calling for help, and so he left us. But now that we were completely, if there was a second shooter, which there rarely is, but if there was, we'd be very vulnerable. So that is just one more reason why it's really good to involve your security and police in doing these exercises. They learned a lot from that. We did too. But you got to have one armed person at the very least at your CCP. That's what makes it relatively safe. Once we know that there are other victims downrange somewhere, we have got to be able to formulate a plan with security or police to then make a relative safe corridor to those victims and prioritize our care. That can only be done with practice and if everyone's on the same page, because I'm hoping that after we've talked today, you agree that we as medical people can no longer just kind of stand around and wait for the scene to be secure. Because think about it, how long would it take to clear your facility? It would take, conservatively, it would take 3 SWAT teams the better part of a day to clear our facility, all the buildings, and our entire complex. It's huge. Think about your facility. How long would it take to secure that facility? How long did it take them to secure the Aurora, Colorado theater? It took several hours. It's a big place. So, unfortunately, I think active killer incidents will continue. I don't think they're gone away. I think we have to change our mindset from if to when and prepare for it. If you ever notice news interviews of people, what do they always say? What does every person interviewed on TV say? I can't believe this happened to us. And it drives my wife crazy because I talk to the TV. And I say, what in history makes you believe it makes it so unbelievable? Right? What makes it so unbelievable? I say, I can't believe it hasn't happened to us yet. So we have to regularly dialogue with our local law enforcement to agree on a response. If you have medical practitioners in your facility, I think you need to at least open a conversation about what are our priorities of care and what are we going to do if somebody walks in that door and starts shooting, or that door. What if we get a report of someone shooting downstairs? How do we respond? And if your facility is fortunate enough, as I am, to have first responders and paramedics, as well as security, then get them all together. I think 2013 was one of the first times that we all 3 groups trained together. And it was fantastic. We learned a lot from it. I would highly encourage you to do that. And again, that building of the psychomotor skills so that you don't freeze when it actually happens can only happen with active drills. Don't get me wrong, tabletop exercises are a great place to start. It's a great place to open the dialogue. It's a great place to draft your first set of plans. But it can't stop there. You have to commit to the time it takes to actually do the drill. Sound the horns, make people go out there, moulage some victims, and make them carry people, make them apply the tourniquet, make them do an airway maneuver. You'll be amazed at how much you'll learn about yourself, but also about your facility and your staff. Doctors, nurses, first responders, techs, whoever. By doing so, you view this as a health issue as opposed to a social issue. I'm truly thankful for the opportunity to come and talk to you today, because I think this really is an occupational medicine issue. And hopefully, again, I hope I had enough handouts. If not, my email address is here, d10@sccmo.org. But if there's any other questions I can entertain for you, I'd be happy to take it. But thank you very much for your time. I appreciate it.